So this is season 2, episode 1. It premiered last night with the end of the first season where there was this mass shooting where all the patients came into the emergency department, and now we're picking up in a new season, a new day. And I was saying that each episode is an hour during the shift, just like in last season. And watching this, I sort of felt like it was just going through patient presentations, and I'm not sure that there was like a unifying storyline, which maybe is just because it's like going into work for a day. I don't know.
Yeah, I guess we'll see. It's an interesting, like, a lot of medical dramas of the past have done the like case of the week, right, as like a lot of the themes here. And actually the Pitt has done a lot of like theme of the week as opposed to case of the week, right? Like trying to connect the dots between different presentations and saying something about the healthcare system. But interesting to see if they fall back on the like patient case to make stakes as opposed to some of the other stuff that we've talked about before.
Yeah. I also think it's just so realistic. Like it just feels like being on a shift. And I'm not sure if that makes it like more quotidian or I don't know. I just find it super interesting. And also sort of triggering. Like, it's sort of like I'm going in and like being at work.
Yeah, I could totally imagine that. For me, it's like, oh, glad I didn't pick that job. But for you, it's a harsh reminder of the intensity of some of the work.
It's a harsh reminder. Yeah, I like that.
But it's also, increasing awareness of the whole world to how intense your job is, which I think is a useful thing. I don't think people realize the intensity of an ER shift and what the weight that you carry during that time. It's, it's crazy.
Yeah. Not every shift is as intense as one of these shifts are. I also think it's interesting that I think it's probably people who watch the show, it's probably affecting their expectations as they come into an ER. I think it's also like setting a baseline for clinical standards too, in kind of this weird way. Like last time we talked about the way that MRIs are used in stroke care, or this was like in a previous episode. And at the time, the ERs where I work were not using protocols like that. And now they are starting to use those protocols. So I think it's pretty like bleeding edge, like the stuff that they're showing.
Yeah. That's powerful. I don't think we've ever had like a healthcare TV show that was in front and really trying to kind of shed light on things or invest that much thought and energy into the type of clinical care they were showing to get some of these things so right. That's awesome.
Yeah, cool. Let's watch some of this stuff.
Let's do it.
Get ready to step up here, Joy. Vocal V off the chest. Clear.
Still a VTAC, but it looks weird.
We haven't considered all the T's.
I checked for tamponade and tension pneumo.
If it's a pulmonary or a cardiac clot, T&K could save it.
We are sticking with the algorithm for now.
Stop compressions, we're calling it. Sorry, the patient's dead.
Yeah, so a little education with the sim man, which happens all the time. Like, this is how we learn. And often done in the trauma bay. Like, they'll bring in one of these mannequins and run simulated codes just for educational purposes.
That was a great scene. I enjoy the reveal of the mannequin. Yeah, this is one of the advancements in medical education of probably the last like 10 to 15 years, maybe, of doing this at a bit more systematic level where we've got like good mannequins and trying to build protocols around simulation. I think it's been really helpful for a lot of people.
Yeah, there are different brands of these mannequins, and some of them, the educator kind of sits behind the curtain and can control what actually shows up on the monitor. So that's pretty realistic. Like when they look up at the monitor and there's vital signs and a rhythm that they're supposed to interpret, that's actually how these simulations are run. There's somebody like controlling it from across the room. So they go through these H's and T's, which is a mnemonic to remember the reversible causes of cardiac arrest. It's like all of the H causes and then all of the T causes. They are kind of going through them and running what we call the ACLS algorithm, the Advanced Cardiac Life Support algorithm, which is the set of steps that you use when a patient's in cardiac arrest. And there's this particular rhythm on the monitor, so they're trying to figure out what to do. They identify it as VTAC, ventricular tachycardia, but not the particular subset of VTAC. She missed that it's this particular type of VTAC called torsade. She gives the like proper French pronunciation.
That's the first time.
That's the first time I've heard it that way too. Yeah.
Flex on it that hard.
Yeah.
Like, oh wow.
Yeah, most people just call it torsade or torsade de point.
Yeah, some people even pronounce the S at the end and
Yeah.
just say torsades.
Torsades, yeah, exactly.
It's not, we're all just trying to get by.
That's
here,
right,
So it's okay.
John Doe, dishwasher, penetrating trauma from a kitchen knife to the right chest. Initially had a pulse, lost it 2 blocks away.
What do we got, party people?
So I want to pause it for a second. So this guy was stabbed in the chest, and the medic says he initially had a pulse, but then lost it on the way. And so that's penetrating trauma with a witness cardiac arrest en route, and that has a very specific implication that we're going to see here in a second.
Calls, major MBCs, GSWs.
28 French on along Kelly.
Body, you're on section. Whitaker, get ready for internal compression.
I am in. Hook up the thoracil.
Okay, so let's pause for 1 second here. So this is a trauma arrest, meaning somebody had a traumatic injury and then their heart stopped beating. And a trauma arrest is like one of the most dramatic kind of presentations to the emergency department, because a trauma by itself is often very dramatic. There's a lot of people involved. The injuries can be kind of scary or, again, just sort of dramatic in presentation. The fact that the injuries were serious enough for the patient's heart to stop beating, that like obviously ups the ante, but just means that there was some really terrible trauma that this patient kind of endured. And so the even higher tier of that is in a penetrating trauma, traumatic arrest, where vital signs are lost en route. That's an indication for what's called an emergency department thoracotomy, where the chest gets opened up to try to resuscitate the patient. This is, in most places, very rare that this gets done, because all of those things have to line up. It has to be penetrating trauma with vital signs lost en route. But unfortunately, in some centers that see a lot of penetrating trauma, hospitals where there are a lot of gunshot wounds in the surrounding area, for example, this is more routine. So I've worked in places where this essentially never happens, and I've worked in places where this happens like every day, which is kind of crazy.
Blood loss is slowing down.
That's a good sign.
Item looks dry.
The heart feels empty.
Okay, we fixed the leak. Now let's fill the tank.
So the patient's bleeding. Again, that's the problem. He got stabbed. He's losing blood. That's why his heart stopped beating. And they're doing surgery in the trauma bay, in the emergency department. They're trying to figure out where the bleeding is. And again, it sounds like there is a trauma surgeon there. I guess it's the trauma fellow.
Yeah.
But yeah, that's trauma surgery. Like, they're trying to stop the bleeding from the patient who's bleeding because of a traumatic injury. And they're just going through these various maneuvers of like, where's the bleeding coming from? And then he calls out this like particular unusual maneuver where they're going to rotate the lung. The hilum is like essentially where the lung attaches to the middle of the body. So he's going to twist it around because that's where the blood flows through. So to try to stop the bleeding there.
Yeah, they're like trying to twist the hose essentially by taking the lung around. There's something obvious happening here that is worth calling out, which is that it takes pretty high stakes to do surgery outside of a sterile operation.
Yes.
And typically where we draw like a clear line between, a procedure that can be done in like an ED room or something like that versus when we're really cutting into the body. And therefore we have to make sure that we don't introduce bacteria into the body because people can get very bad infections. Typically you would want what's called a sterile field. The patient's prepped, everybody goes through a very specific process to wash their hands and put a particular type of gloves on. In these situations, there is kind of a rare opportunity to do surgery in one of these rooms where you kind of turn what's called the trauma bay, which, throughout the day is a normal room, but you turn it into an operating room temporarily while you're doing this. Yeah, truly what is surgery?
That's right, yeah. And that's why, you might say, well, somebody who gets hit by a car, for example, and their heart stops and they come into the trauma bay. Like, will this happen? Do we typically cut open their chest and try to stop the bleeding? The answer is no, because that's what we call blunt trauma. Car accident's an example of blunt trauma, where your whole body hits a surface. A fall from height or a car accident are both types of blunt trauma, whereas a gunshot wound or a knife stabbing are penetrating trauma. And in a penetrating trauma, there's more of a chance of like finding that one spot where the bleeding is happening and turning it off and stopping that bleeding. which is why only in that very specific case do we basically do surgery in the ER, which is otherwise a terrible idea. As you said, there's a risk of infection, there's a risk of worsening the bleeding in an uncontrolled environment. But in that particular case, to try to save the patient's life, the studies have shown that it's worth doing this heroic procedure. And you notice that, I think it was the trauma fellow or the trauma surgeon at the beginning made a snarky comment, well, he's dead anyway. And the reason is that most patients who don't have a pulse, who arrive in the ER after a trauma in cardiac arrest, she's right, statistically, there's a very low probability of survival, but some do survive, which is why we do the procedure.
So there's the kind of mechanical work to try to figure out if that blood is accumulating somewhere that cause a problem and to try to fix what's going on. And then they mentioned massive transfusion protocol, which is a specific protocol. Well, they will give blood through an IV, typically through a specific machine sometimes that can actually give blood faster than a typical IV would, just hanging from a drip. And it invokes a certain amount of blood that they're going to be delivering over a relatively short period of time. So these kind of it's a real kitchen sink moment for trying to save this patient.
Yeah, that's right. Massive transfusion protocol. The idea is that you're bypassing the match. Typically, if somebody gets blood in a hospital and it's not an emergent situation like this, if you have time to get blood, they'll take blood from the patient and cross-match it and type it against the blood that's going to be given to the patient. So everybody's heard of blood types, A positive or B negative, to make sure that the blood you're getting matches. But in this case, in the massive transfusion protocol, they give O blood, typically O negative or sometimes O positive to certain patient populations. And that is the universal donor. So anybody can receive that blood without there being a mismatch. So yeah, massive transfusion protocol. They're just like taking the blood out, giving it to the patient in big quantities as fast as possible.
No tamponade. Pretty dry in here. Heart's empty. Somebody start cardiac massage. I'll cross clamp.
You do these one-handed, pushing up against the breastbone with 4 fingers.
They love the moments where they can show off Dr. Robbie's calm.
Yeah, that's right.
And they just half the show is just throwing shit at that dude and watching him smile and make, kind of funny, witty comments throughout, while everybody else panics around them. So it worked well for that. So there's 2 ER attendings in this room right now.
Yeah.
Is that a common thing, you think, that the 2 attendings would be kind of overseeing this at the same time? Is that unique to this being her first shift at this hospital, or what's that?
Yeah, I would say that's uncommon. So it is common for there to be an emergency medicine attending and a trauma attending in the room. That's the most common setup. And certainly if a patient is very sick or needs a lot of resources, like another attending or other team members will come in the room to help out. But it would be pretty unusual for this to be the moment for, oh, it's your first day, how's it going? How are things at the VA? Either somebody coming in to lend a hand, absolutely, to observe, absolutely, or kind of just, staying away and seeing the rest of the department while there's a team dedicated to caring for that one particular patient. Because as you see, there's a waiting room full of people, none of whom know what's going on in the back. So that's something else to remember.
Frank?
By the way, I never walk through the waiting room on the way to a shift.
Yeah. No, that's what I was like. Is he a patient? Is that what they're trying to show here? But it's just kind of a strange.
At the beginning, Dr. Robbie walked through the waiting room too, coming in. Yeah. It's not for me.
Yeah,
more power to him. I sort of gotta get my game face on and take a minute before the shift starts.
Yeah, I think that makes a ton of sense.
I love that with the sandwich. I feel like that's so on point.
Right. And he's coming back. He's getting he's got a lower locker. He's demoting. He's on the ground, and then there's somebody's leftover food in the locker.
Oh, that's funny because you're totally right. I interpreted it more as it's just this crazy place, and it's a 24/7 operation, and things are left behind. There's always food around, and yeah, that's funny. I didn't even think of it as offensive to him. I more thought of it as par for the course. old food in the locker.
Yeah. What I couldn't tell, it seemed like the beginning of this, like that was his old locker, maybe the one that he went to reflexively, and like the code didn't work anymore, and then maybe was assigned a new one. I don't really know, but yeah, it is par for the course.
VTAC, no pulse. Should we call for a code blue?
No CPR, no shock. We honor his pulse and his wishes.
They look so peaceful, quick and painless. We should all be so lucky. I'll try to contact some family.
Yes, so while they're at the bedside discussing what might have caused this person's change in mental status, his confusion, this rhythm appears on the monitor, VTAC, ventricular tachycardia, which is back to the case that we saw earlier in the simulation. And the student feels for a pulse. There's no pulse. So this is a patient in cardiac arrest. So at that point, he says, should I call a code blue? Because this is a patient who needs to be resuscitated. His heart has stopped beating and essentially needs a shock to restart his heart. But they don't do any of that because they see that the patient has an advanced directive and didn't want to be resuscitated. And so they let the patient die. They let him pass away. And that's, that happens sometimes. I don't know how long this patient had been in the ER. It's often the case that there's confusion when they first come in. We want to reconfirm what their wishes are. Maybe they didn't come with paperwork, and we reach out to family and kind of reconfirm what the patient would want if their heart were to stop. Would they want to be resuscitated? Usually in the ER, there's like a little bit more activity around something like that where there hasn't been so much time for it to be very clear cut that we know what this patient's wishes are. If they if they their heart stops, we're not going to do anything.
Well, and you're right that if you don't know the answer with confidence, you will err on the side of resuscitation.
Right.
And try to figure out as fast as you can, of course, to the best of your ability. But this is where I think about this a lot in the primary care setting.
Right.
Because my patients are people I've known for years. And when they have either reached a certain age or have a certain number of comorbidities or medical conditions where they are very unlikely to meaningfully survive resuscitation, right, is when we really think about this notion of a DNR or a do not resuscitate order. And it's always a tricky conversation with folks, right? It can be a pretty scary thing to talk about for a lot of people, to think about the end of their life and to have these kind of complicated conversations around what they would want for themselves. The problem you mentioned, which is people not knowing when they go into the ED, is a very real practical problem here. Because even if I've had hours of conversations with a patient and we've signed all the paperwork and they are like really comfortable, they want the DNR, let's say, and that's the life they want. But let's say they have a cardiac arrest at home.
Right.
And the paramedics come, they pick them up, and let's say there's no one there that knows about the DNR order, they're going to start resuscitation right there in the field. And so one of the things that I've done with patients is, we have a separate copy of the DNR, and we put it on the fridge. And we put it on the top of the fridge with a magnet on it in a place where a paramedic would have a very, would be able to see it easily. In New York, they're pink, and they're like kind of a pink, bright piece of paper that are a little bit more easy to see. But it's kind of a tricky place where things can fall through the cracks.
Yeah. The term that they use is POLST, which is the type of form, POLST, is like the form that they sign to like memorialize your wishes in terms of do not resuscitate. So while they don't say DNR in the scene, that's what they're talking about. I would say also, if you complete that paperwork, make sure that your family knows about it, because we will almost always reach out to a family member to try to confirm the patient's wishes. Obviously, the last thing that we want to do is like follow an outdated piece of paper and not resuscitate somebody who, whose wishes were to be resuscitated. So as you said, we often will err on the side of resuscitating someone until we know with certainty. And the way that we often know is by talking to a family member.
Yeah. And people get to change their minds on this.
That's right.
Right. Just because you signed the paper once doesn't mean that is going to always be your wish. It's a dynamic process, and it's obviously a very complicated question. And so, even if you have the piece of paper, but it's pretty old, it's not a simple situation to be in as a physician by any means. But yeah, I totally agree. Family member or whoever your emergency contact is, in your medical record, who your healthcare proxy, whoever that is, if they have a good sense of that, I think you're in a much much better position. And you could Google and actually just take a look at what this form is. It's a publicly available form, even if you're just curious to understand how the wording is, because they do talk about not only would you want resuscitation in the case that your heart stopped beating, but also if you weren't able to breathe on your own, would you want a breathing tube? If you weren't able to eat on your own, and that's less of an acute situation typically on the eating side, that's usually more over days to weeks. Would you want a feeding tube placed to help you with artificial nutrition? So there's a whole bunch of different kind of domains here that are relevant for folks, and you can take a Google and see that.
Appendix is a concierge practice where we meet privately with patients, and then we meet as a team of doctors and discuss patients anonymously. So we're accepting patients into the practice. Check it out at appendix.com. You get a much more robust discussion around your care because we're bringing in all of these experts to discuss it out in the open. And so, yeah, check it out, and we'd love to have you.
You know, one of the amazing things about Appendix is we're bringing together a team of doctors to talk about your case. And this doesn't happen at all anymore. Even at big academic medical centers where there's a lot of people working at the same institution, no one really talks to each other about a given patient in a way like we used to. And I think both you and I know that those settings and those conversations are where we really get to interesting depth, because 2, even 3 minds together on a given case can really achieve something that a single doctor can't.
And so the way that it works is patients come in and they meet with one doctor privately, and then that doctor goes to what's basically a round table and discusses it with the whole group, keeping the patient anonymous. Like, we'll say this is a 40-something male, this problem, or a 50-year-old female with this issue, and we go through and discuss it more broadly with the whole group. And all of that knowledge we are making public, so we're actually sharing those video clips of the doctor discussion publicly so that everyone can learn from them. And of course, it adds this whole second and third dimension of care to the patient who came through the door initially.
No obvious source of infection.
Under 28 days is a safe haven drop-off, no questions asked.
Under 28 days gets everything, including an LP, but over 28 days, you can follow PCARN or step-by-step to determine risk of invasive bacterial infection.
What they're getting at is that in babies younger than 28 days, a fever triggers an automatic septic workup. The idea is that in a baby that young, a fever can be an indication of a serious bacterial infection, and so we have to go searching for what this infection might be.
Seems happy enough.
Okay, just got a quick point of care CBC.
Is there a problem? Did I miss something? Dr. Al? Dr. Al?
I'm not sure I understand. I don't know if they saw. So she says here's a quick point of care CBC, so a complete blood count. They're looking at like one of the initial blood tests that they sent on the baby. I'm not sure if they're reacting to what's on the blood test or if there's some like interpersonal story here. I don't know. I guess we have to see on the next episode.
Yeah, it seemed like there was something getting pulled on for this attending, Dr. L. Like there was some emotional reaction to like they said, I'm not sure exactly what it was. Yeah, because on a CBC, we can talk about a few things that you can see on there, which is you get a white blood cell count, which tells you your risk of having an infection, your hemoglobin, which is kind of the red blood cells or the ones that carry oxygen to different parts of your body, and your platelets, which help clot off when you get cuts. And it's a good first pass look at is something seriously wrong? Because when one of those numbers is very off, it usually means something pretty bad. But especially in, I think, a pretty young baby in this situation. But I don't know.
Yeah, guess we are going to find out. Episode 2.